Yeah, good morning, good afternoon, everyone. We'll just wait a few minutes for people to kind of file into the virtual waiting room. I'll scan the list of participants to see if we have any friends and repeat offenders on the call. Oh, nice. Louise, I see your messages. I'll get to you. Mary Hand, nice. Lance Timmons, greetings. Oh, nice turnout. Bunch of familiar names, some new ones as well. Stafford Cohen. Dr. Cohen, so glad you could join us. Wow, Dr. Ray, good to see you. Outstanding. All right. Well, it's 4 o'clock. We've given everyone a little bit of time to file into the virtual meeting room. My name is David Hiltz, and I am the director for the Citizen CPR Foundation's HeartSafe Community Initiative. This is our monthly Champions webinar. Each month, we look to bring in an interesting subject matter expert to talk about various aspects of the HeartSafe program and resuscitation in general. And for those of you who have done these in the past, you know that um, they're seasonally themed to a certain extent. And while I know that we've got some folks from other parts of the globe on the call, here in the United States, we are entering into the warmer summer months. And so I thought it would be appropriate to talk about um, some seasonally appropriate topics. So, on behalf of the Citizen CPR Foundation, I welcome you to our monthly webinar. The mission of the CPR Foundation is here in front of you. I would draw your attention to the three core values that form the basis for our events, and that's, we know that early bystander initiated CPR and rapid defibrillation are proven lifesavers, particularly when combined. We also know that collaboration amongst diverse groups is necessary to improve outcomes from cardiac arrest, and that actions based on best practices in science, education, and implementation will do a great deal to improve outcomes. I'd also like to take a moment to recognize the Citizen CPR Foundation partners. Um, Without their support, this webinar and our life-saving campaigns would not be possible. So, hats off to each and every member of our partner council, and thank you for your ongoing support. All right, there we go. So announcements, always make space for announcements from our peers out there. I received no announcements to share with you, but I will let you know that up until today, I typically did a mad dash from an orientation webinar on HeartSafe, and I would jump into a phone booth and change clothes and end up at this Champions webinar. The good news is that we have now recorded one of those vodcasts, and that will be available on demand, which should make it easier for interested parties to share and take up at a time and location convenient to them. Also very excited as a member of the core conference planning committee with the Citizen CPR Foundation that the Cardiac Arrest Survival Summit program is finished. And we're on the cusp of releasing detailed information to the masses on that conference, which is scheduled for this December in sunny San Diego. And so for those of you who haven't yet saved the date and thought about attending, give it some very serious consideration. If you're on the fence, certainly take a look at the program and register accordingly. Myself and many members of the resuscitation community are very excited about this particular conference. So today, and I apologize, I am nursing an upper respiratory infection that seems to be lingering on, so I'm sputtering a little bit, but I'm really absolutely delighted to have Justin with us today, who is with, not only is he an emergency medicine guy, but he's founded the Lifeguards Without Borders and the International Drowning Researchers Alliance. And so today, we're going to take some time to talk about facts and fallacies in recognition, prevention, and preparedness in regards to drowning and the drowning chain of survival. I don't know if you can see the subdued image in the background, but this should be a very meaningful talk. I know Justin wants to talk a little bit about treatment of drowning. We'll see how that goes. I could open up an entire show just to talk about my own personal feelings about how we train lifeguards, but that would be a webinar in and of itself. So, from a historical perspective, I think many of you recognize this image. It's interesting when we draw lines backward from a historical perspective to what we're doing today. A great deal of what we're doing now has its origins around care of drowning victims. And again, there's a lot of information on that in and of itself from a historical perspective, but realize that drowning is very closely connected to what we do in resuscitation. And it's not just about CPR, right? There's a lot, and that's why the focus today is really about recognition and prevention, because we know that, all patients in VF can and should survive, right? But I see drowning victims as truly preventable deaths, right? This is totally preventable because we assume that they're healthy, right? And this isn't a primary cardiac issue, but one that was caused by water hazard. As a reminder, you'll be muted during the call. We typically open it up in the end. We'll open up the mics, but please use the Q&A or chat function in the Zoom application to capture your comments as well as your questions so that we can address them later on in the webcast. So, I've made a bunch of introductory remarks, and again, I'm going to look to pass it over to Justin. We're going to talk about a wide variety of topics, including, perhaps some innovations like, training surfers to be lifesavers, right, as a target audience for, training because they're likely to be there. So with that said, I'm going to go ahead and stop the share here and turn it over to Justin. Justin, welcome. The
Thank you
floor
very
is
much.
yours. Why don't
Thank
you
you
tell
very
us?
much.
Why don't you tell us just a little bit about yourself, and I'll hit you up with kind of the first leading question.
Yeah, absolutely. So I'm an ER doctor by day. I started out as a beach lifeguard in Jacksonville Beach, Florida in 1996. And that's really where I kind of first felt that sense of that pre-hospital and EMS and drowning community. And after I went to undergrad there in Jacksonville, I kind of decided that I wanted to be a lifeguard forever. Even though I did pre-med and took the MCAT, I didn't apply for medical school because I just wanted to be a lifeguard forever. And the city at the time said, well, if you guys all become EMTs, then we can let you be lifeguards forever. So we became EMTs, and they said, well, you've got to go to the fire academy in case you get absorbed by the fire department. So then we all became firefighters, and they said, okay, well, what if you were paramedics? And then it was kind of while I was in paramedic school with a few of my other lifeguard colleagues that we looked at the textbook. And by then, between the three of us, we had about 40 years of ocean rescue experience, and kind of raised our hand and said, well, what's in the textbook doesn't match the practical reality of what we've encountered over our years. And we got the very stern, it's what's in the textbook, it's what's correct. And that was kind of the moment that pushed me to say, you know what, I think now this is the motivation to go to medical school so that I can be the one to go back and rewrite this textbook and have that practical experience match what's taught. And then went to medical school. And while I was there, learned that more than 90% of the world's drowning deaths were in low and middle income countries, which prompted another lifeguard turned ER doctor, a friend of mine, Dr. Andrew Schmidt, to form Lifeguards Without Borders. And then from there, kind of jumped into the world conferences on drowning. And the handful of us from around the world who really became dedicated to this drowning cause, started meeting in hallways and restaurants and bars in the years between conferences, and formalized that by creating the International Drowning Researchers Alliance so that we could have a place for other budding researchers or established researchers who are interested in the drowning space to kind of come and work together. And to bring that story full circle, I met up with and worked with the chief editor and author of that same paramedic textbook, Dr. Brian Bledsoe, and he gave me the opportunity to rewrite that drowning chapter in his textbook, and so was able to kind of complete that initial mission right after finishing medical school.
Wow, Justin, you know what? I'm really happy that I answered that question, because when you shared your bio with me, it was kind of a little bit scant, if I may, very unpretentious. And I suspected that there was more than a kernel of interesting story in the background. So thanks for sharing that with us. Now, thinking about the focus for today, facts and fallacies and myths. Um, why don't you take a dive in here and kind of hit us up with, what are the biggest fallacies and myths around drowning, and set us all straight here.
Yeah, absolutely. So I think something as simple as the definition of drowning is even widely misunderstood. And it seems simple, right? Somebody goes in the water and they die. That's drowning. Well, believe it or not, before 2002, there were actually 33 different published definitions of drowning, 20 alone of the term near drowning. And so as a beach lifeguard, we could rescue somebody from the water, CPR in progress, send them to the hospital. And when they were pronounced dead 3 minutes, hours, days, or weeks later, the cause of death would be anoxic brain injury and respiratory failure, right? So nobody died by drowning. They died by anoxic brain injury and respiratory failure. So at the first World Congress on Drowning in 2002, proposed a definition and said, drowning is a process. That process starts with respiratory impairment, either when the person's underwater or getting so much water splashed in their face from surf, white water, a water slide, that they get respiratory impairment. And that process can result in death, but drowning doesn't equal death. And we wouldn't call somebody who survived a sudden cardiac arrest a near cardiac arrest, or somebody who survives a stroke a near stroke. We would just say they had a stroke and survived. They may have some minor morbidity. They might have a little bit of weakness in their non-dominant hand, a little bit of confusion, or they could have, require 24-hour care for all of their activities of daily living, but you would say that they survived their stroke. Same with drowning. You can drown and survive with no complications whatsoever, or you can drown and survive and be completely dependent on 24-hour care and everything in between. So drowning is a process, not an outcome. You can drown and survive.
Ah, well, that's extraordinary. And, I have some recollection of this actually happening, right? And, it's interesting that it's described almost as a process of dying, right? And, geez, reporting of causes of death is certainly a sticking point for many of us on the call, since cardiac arrest isn't a reportable cause of death and is often chalked up to other things as well, such as natural causes, right? There's nothing
Yeah.
natural about it. So
And I would
hit
say
us
I would
up
take that
again.
even a step further, that we in the drowning research community borrowed from the cardiac arrest literature and all of the success at the Utstein Abbey conference. And so we actually developed a Utstein style template for reporting drowning incidents as well for researchers and public health advocates as well. And so there's actually a Utstein style template for drowning,
Yeah,
modeled
so
after the cardiac arrest.
the degrees of separation are like this, right? And interesting, again, you plug in the term public health, right? Drowning is a public health issue. Cardiac arrest is a public health issue. Carry on, young man.
Yeah, absolutely. And so with that, if of all of the cardiac arrests in the U.S. at least is where I'm more familiar with the numbers, but about a quarter of those are the sudden cardiac arrest that are appropriately treated with that early CPR, early defibrillation, and that cardiac chain of survival. And the rest of that chunk really is made up of a smattering of different etiologies. And whether it's a car collision, a gunshot wound, sepsis, or drowning, there's different ways to address and treat those. But with all of them, really prevention is more important and can carry more weight than treatment. And I know that I talk a lot about treatment, not because it's the most important, but because that's my niche area of expertise. But my colleagues that are focusing on prevention are saving far more lives out there every year than the doctors and lifeguards performing resuscitations.
Yeah, interesting. That adage, an ounce of prevention is worth a pound of cure every day. So that's actually a nice segue, Justin. And knowing that we've got a diverse audience here, and ultimately we're going to look to wrap up our webinar talking about some community strategies to help in prevention and recognition, lesser extent treatment. Can you tell us a little bit about prevention? I'm getting the sense that there are some global kind of prevention kind of approaches to that, but then some that might be more specific to certain geographies and settings. So please carry on.
Yeah, so again, the nod to our public health colleagues is we really need to understand the problem before we can address it. And in the U.S., the group with the highest risk of drowning is kids aged 1 to 4, typically in settings where they were not intending to be in the water. So it's right as the toddlers are getting mobile and brave enough to slip out through the sliding glass door towards the backyard pool, or to slip away while out at the park, in the neighborhood and get into the pool area. And it really only takes those kind of momentary lapses. And my son is 6 now, but I can tell you it's hard to watch them every second of the day when they run away and you've got to move the laundry or answer the door to sign for a package or things like that. And that's really the highest risk time, particularly when they're in the care of a non-primary caregiver. And this could be a babysitter, an aunt or uncle, or even grandma or grandpa. And with all due deference to my parents, that again, fill them with sugar and send them back spinning like the Tasmanian devil. That level of supervision just is no one's ever going to beat the primary parent in that degree of hawkishness and knowing what different cries mean and which cries mean run now and which cries mean. I'll get to it in a moment.
Yeah, as a parent myself, um, and having lived on the shore for most of my life, between Long Island and Rhode Island, uh, I got to think, gosh, how fortunate I've been. Because monitoring your children at home is certainly one thing. Monitoring them out at a public beach is certainly another. And so, a point of clarification with the 1 to 4 year olds making up a major portion of the victim population, if I may. Justin, are most of those occurring in and around the home or elsewhere? And is there kind of regional differences in those statistics?
So most of those are occurring in backyard pools or canals, small inland waterways that aren't necessarily navigable, that are just within the reach of the home. So it may be an irrigation ditch or canal, it could be a retention pond, or other just bodies of water that are close to the home that they're able to get into. And the recreational setting, whether it's a water park or a beach, are actually the lowest percentage of those. So you would think that Florida, Texas, and California would have the highest drowning rates because of their coastline, but they have the highest drowning rates because of the number of swimming pools and not necessarily because of their coastlines.
Oh, well, interesting, right? And there's a part of me, I mean, every single one of us have lived through this past year and the pandemic. And I see that my neighbor's putting in a pool this summer. But I would have to imagine there was an explosion of backyard pool construction and things of that nature during the pandemic. Um, do you have any data that is current that may have shown that the pandemic had some kind of an effect on drowning fatalities?
So we've been nervously awaiting that data because part of the layers of protection for prevention are pool fences, pool alarms, self-locking gates, and those things, but also swim lessons. And with the shutdown with the pandemic, most aquatic facilities were closed. And so we see a big drop in swim lessons. And if that truly did cause an increase in drowning deaths, it may be a couple of years before we see and are able to truly parse out that data, because by not having a swim lesson when they were 1, well, then it kind of gets put off when they were 2, it gets put off when they were 3, and then now they're 4 and have that increased risk if they do fall into the water. Whereas if there was no pandemic and you would have enrolled them at 1 like you had planned on it, well, then now it's easy to enroll them at year 2 and 3 years old and 4 years old and kind of get that chain started. And we know that parents who themselves can't swim are less likely to teach their kids to swim And once you get them swimming, then it's easier to get subsequent kids trained in swimming as well. And so it's the type of event from the public health standpoint that by not having that available and not getting that done on the front end, that there may be back end consequences that we don't see for years.
Learning to swim seems as important as learning CPR, right? So, fences and barriers and locks and alarms can only do so much, right? And having competency and preserving your own life by being able to swim seems to be of paramount importance. And, I hadn't even thought of, how the pandemic, I thought of, certainly a proliferation of pools. Along with a proliferation of pools comes, more unsupervised youngsters and an increase in drowning. Didn't even think about the swimming competency kind of thing. Like, wow, very profound observation, disturbing at the same time. And, you know, I'll probably remark at the end, but, like once upon a time, there used to be requirements here in the United States about, being able to swim in order to get out of university. But we'll probably come back to that shortly. Can you tell
And
me?
so
Yeah, go
just
ahead, Dustin.
yeah, real quick, if I could kind of finish out on the on that prevention. So, and then outside of the home, when you are at the pool, when you are at the beach, it's really that direct, uninterrupted, capable adult supervision that for this age group really requires touch supervision, where they are at arm's length and you're not texting, you're not on social media. Sometimes that means even putting down the phone to not take pictures if there's multiple kids. But then the other really high risk time that we see going into the summer is backyard parties. Whether it's intended to be a pool party or not, if a pool is present, every adult there assumes that every other adult is watching all of the children and watching the pool. And sadly, we hear too frequently stories where everyone assumes everyone else is watching the kids, and nobody notices that one of the 3-year-olds who was running around with this group of peers is now not with that group of peers and have gotten into the pool and drown. And so we advocate for the use of water watchers, which if you just Google water watchers, they'll come up with a dozen different nonprofits that make tags. But basically it's a physical something to hold in your hand that says, while I'm holding this, I'm not drinking, I'm not eating, I'm not texting, I'm not taking pictures. My sole responsibility is eyes on the pool. Even if there's nobody scheduled to be swimming, it's eyes on the pool to make sure that nobody goes in the water. And only when I hand this off to another adult every 15, 30, however many minutes, do they then become responsible. And it doesn't have to be a water watcher tag. It can be a whistle, it can be a spirit stick, it can be, the coach's clipboard, whatever it is that you have, that's that physical something in your hand, is that reminder of I'm not doing anything except watching the water during this time, and I'm not going to let go of that responsibility until I hand it off to another responsible adult.
Oh, that is an outstanding idea. I love it. As long as it's not like hold my beer, right? Right.
Right.
Right. So again, the parallels are fascinating. A diffusion of responsibility when it comes to supervising a water hazard, and a backyard pool is just as much of a hazard as open water. Wow, that's a great idea. Loving it. Loving it. Um, Tell me a little bit more about water parks, because I've been involved with working with several water parks on enhancing their safety in general, and I know that they do a lot of drilling with like all of a sudden a little infant mannequin will come shooting out of the slide at the water park. Tell us a little bit more about what's happening in water parks. I'm profoundly curious.
Yeah, so for whether it's water parks or just other public or private aquatic facilities where they have lifeguards, because I would, kind of lump them all in together, is it's the type of activity where we hope that we never need to use them, and we train our lifeguards primarily in prevention, and we want them to prevent accidents from happening. And then when something does occur and they have to perform a rescue or they have to perform CPR, if they haven't had realistic practical based training on how to do that, then how can we expect them to perform to the level that they're trained to, which is typically CPR for the healthcare provider or CPR for their professional rescuer is the level that they're trained to, but they're not seeing it on a monthly basis like some of our colleagues in the hospital or in other aspects of EMS. They may never see it, and we hope that they never see it. And so these drills are a way of helping them maintain that vigilance for not only performing rescues, but also for providing treatment as well. And a big lesson learned from our sudden cardiac arrest and EMS colleagues is the use of team focused CPR or pit crew CPR, or all of the other names for it, but basically that everybody has a pre-assigned role. So it doesn't matter who I'm on shift with. I know that the first arriving guard does A. I know the second arriving guard does B. And based on today's drill, I'm guard 3. So I know that means I need to grab this piece of equipment, and here's where I fit into that role. And just like our F1 or NASCAR pit crews, if you're not training and practicing those roles, then you can't expect them to be streamlined during the big show. And there's no doubt about it. Even for seasoned emergency physicians, resuscitations can be stressful and are stressful, and it really requires some experience for it for us to get our own heart rate down, to be able to provide care. And so these exercises are some of the stress inoculation of the lifeguards to be able to better perform during the actual event that we hope they never see.
Yeah, exceptional, right? And now, but I think of real world, right, applications. And as you know from our previous discussions, I come from a family of lifeguards. Not me, but the wife and all 3 boys have been lifeguards. And I recall stories from my wife, who was a guard at a place called Burlingame State Park in Rhode Island. And she told me stories as a youngster of if there was an emergency, she would have to run about a half a mile to a phone. And she was the only guard there. And so, while we hope that, most of our waterfronts are covered in the manner that you discuss, where it enables high performance CPR and so forth, we've got a lot of lone lifeguards out there, including said wife to this day, who is a lone lifeguard for a YMCA pool every Friday. I know because we get up at 3:30 in the morning. But the single rescuer kind of scenario is one that I don't relish thinking about a great deal. But before we transition, Justin, uh, how prevalent is drowning in our water parks? Because I kind of like going to those places.
Yeah, I would say overall it's relatively low, and probably one of the lowest risk environments based on exposure and usage. Especially if they have lifeguards that are trained, both trained and qualified, right? So you wouldn't hire a firefighter or an EMT just because they had the a certification card, you would also then train them once they arrived on your specific equipment, your specific protocols, your specific environment. Same with lifeguards. And most of the water parks are run and have their lifeguards managed through any number of a handful of professional lifeguard training agencies that include audits, that include some of those secret shopper type drills, that include both in-service training and qualification in addition to just certification.
Yeah, so interesting. Again, a lot of our principles in the arena of cardiac arrest treatment, recognition, and treatment apply to your group. So it appears again that there's a lot of kind of cross-pollination and sharing of things going on. So very, very profound. Tell me a little bit about this concept of drowning doesn't look like drowning, Justin.
Yeah, so two parts, and that'll kind of segue right into what my follow up on that, and that is that when we talk about the drowning process, right, we're talking about respiratory impairment from submersion or immersion in water. But we also kind of have that colloquial or common use of the term drowning to mean somebody struggling in the water in need of rescue. And so, from the medical definition of drowning, I kind of went over that. And believe it or not, there's really no kind of standard accepted definition of here's somebody that's struggling in the water. Are they in distress? Are they in need of rescue? And we commonly call that drowning. And so in the movies, we see them splashing and yelling for help. But in reality, they don't splash and yell for help because they are using their airway to try and breathe and not to scream. And they will have any number of different movements with their arms and legs underwater to try and keep the head above water, but it's swift and silent. And in little kids that don't know how to swim, it usually only lasts for about 20 to 30 seconds. And in adults, only about 30 to 60 seconds that they're actually struggling at the surface before they go under. And then circling back to your point that these often occur not in a lifeguarded setting where there's a team of trained and qualified lifeguards. It's happening at the backyard. It's happening out on the lake or out on the river. And so much of the work of the Citizen CPR Foundation is not how do we get paramedics there faster, right? It's how do we train the bystanders that are there to be able to respond appropriately as a bridge to the arrival of formal EMS. And to oversimplify it, to go from alive and well to dead and drowning is about 10 minutes. And for reasons that are a whole nother podcast, right? Our goal for getting EMS to your door in most parts of the US is about 8 to 10 minutes. And so what you do as a parent or as a trained bystander on the side of the pool or after they get pulled into the boat has more impact on their survival than what the paramedics can do, and even more impact than what I can do by the time they get to the hospital 45 minutes later. It really requires the parent or the bystander interrupting that drowning process early and then continuing the other elements of the chain of survival. And I saw a question pop up about, what is that drowning process? And when the person is underwater, most people will lose consciousness in 30 to 120 seconds. So, half a minute to 2 minutes will lose consciousness. And it's often before they ever even try and take a breath. And so they will be unconscious underwater. And as water fills the upper airways, they will have reflexive swallowing, where a lot of water will go into the stomach, but very little water actually goes into the lungs. And so drowning isn't a process of the lungs filling with water. While they're underwater, they may as well be in outer space, not getting oxygen to the brain. And then after loss of consciousness, eventually they stop breathing, then eventually the heart stops. And then once you pull them out of the water, the reason that the heart stopped was because they didn't have oxygen to the brain. So the primary treatment is to get oxygen to the brain as quickly as possible. And so the nuanced difference between sudden cardiac arrest, where somebody suddenly goes into VF or VT, well, they still have dissolved oxygen in their blood. So forget about the airway. Just do chest compressions until the AED arrives so that they can pump their own blood to the brain. So I don't have to do as much work in the form of chest compressions, right? Whereas in drowning, if we are just doing compression only and an AED, well, then we're probably just circulating blood that doesn't have oxygen. And the minority of your drowning patients are going to benefit from or going to be in a shockable rhythm. And the other parallel would be in trauma. If my heart has stopped because all of my blood is outside of my body, no amount of chest compressions and defibrillations are going to bring me back, right? You've got to put blood back into me. Same with drowning. All of the oxygen is gone. We've got to put the oxygen back in. So the best chance of survival for that person, adult or child, is to receive CPR that includes breaths and compressions. And from the zoomed out public health standpoint, the compression only community CPR classes are absolutely phenomenal for treating that zoomed out public health, because even our lifeguards at our water parks see more cardiac arrests from somebody in line at the snack shack or somebody coming out of the locker room that is a sudden cardiac arrest than they do a drowning resuscitation. And so we have to train and treat both. To if this occurs, then we're going to do our sudden cardiac arrest algorithm. If this occurs, we're going to do our drowning algorithm. And then understanding that there's overlap, right? When you've got your 75-year-old lap swimmer who's there every Tuesday and Thursday at 6 a.m., and swims 1,000 meters, you know he knows how to swim. So when he's suddenly at the bottom of the pool, it wasn't because he forgot how to swim. It's because he's had some sort of medical event, a sudden cardiac arrest, a stroke, a diabetic emergency. They just happened to be in the water at the time. And so we advocate for those of you that are taking a CPR class because you have a pool, because you're a grandparent and you're going to be watching the kiddos, that you take a CPR for children, not just the compression only CPR for adults. But now that we're zoomed in on this one specific population that's the reason you're taking that class, then that will train you on doing breaths and compressions.
Yeah. Fascinating, right? And there's still a couple of different populations out there on conventional CPR, combination of ventilations and chest compressions versus chest compression only, CCR, and all that stuff. I still tell people, and this is just my personal opinion, does not represent any of the organizations for which I work or volunteer for. I say, hey, I'll take a combination of ventilations and compressions, but there's always the what if, right? But I insist that the person be competent in doing that, right? So what a fascinating discussion, Justin. Tell me a little bit about, or tell us a little bit about what you might recommend as kind of Justin's top 3 recommendations for, community strategies to improve recognition and prevention of drowning, knowing that that's where the big payout is. Give us Justin's top 3.
Yeah, it would be the emphasis on constant, uninterrupted supervision of the little ones. And then once we get into the college or university age group, most drowning risk factors relate to what I lovingly refer to as testosterone poisoning, which is we males doing stupid things plus or minus alcohol. and that involves the boating safety aspect. But so the first would be that direct, uninterrupted supervision of the little ones. The second one would be wear a life jacket, wear a life jacket, wear a life jacket. And even I see too many drowning deaths from competent swimmers, but they weren't anticipating the water temperature. They weren't anticipating the chop related to that tide. They weren't anticipating that as the weather changed and they opened more flow from the upstream dam, that because more people have their air conditioning on, the conditions were going to change, and they didn't have that capability to do it. And then that third would be from the prevention standpoint is you have to use layers of prevention. And analogous to automobiles, we have seat belts, crumple zones, airbags, driver's ed training, drinking and driving education, texting while driving education. And I hope that I never have to use my seatbelt. I hope that I never have to use my airbag. And the reality is, you and I could both drive for the next year with no seatbelt on and nothing bad happens. And that bad behavior can be reinforced by nothing bad happening immediately, right? There's no nonprofit out there that I'm aware of that tells people not to touch hot stoves, right? The feedback is severe and immediate. But in drowning, I do these bad behaviors. I don't ever wear my life jacket. It's under the seat somewhere. The kids are fine back there. The 7-year-old's watching the 3-year-old, right? And those bad behaviors get reinforced. And so it's really important to have those layers so that when the pool fence fails, or I've got a collection of videos of 18-month-olds climbing up and over 4-foot high pool fences like it's nothing, right? Well, now they've got a swim lesson to fall back on. Now there's a pool alarm that's going to go off when they get into it. And so we can't rely on any one of those elements, that you really have to have those layers of protection for prevention.
Now, Justin, 2 thumbs up from me on the Justin's top 3 recommendations. That was perfect. Now I see a good question from Dr. Ray that we'll probably pick out first. But, it's interesting, swim at your own risk. I mean, you see those signs everywhere, right? And people are like, yep, okay, here I go, Geronimo, into the water, right? Not really thinking about the risks. And, I will tell you in full transparency that I recall times as a youngster doing risky things, guy things, right? Way out in the surf, pre-hurricane, catching the surf and in trouble, and it wasn't until I'm older now that I'm, comfortable in saying, yeah, I was in trouble out there. I thought I was going to make it, right? And you think about how often that's happening. So love the top 3. We'll circulate that with everyone along with some other assets via email after our call today. But Mallory, would you mind unmuting Tom Ray and allow him to ask his challenging question?
Well, sure. Yeah. Hi, David. Hi, Justin. Thanks for a terrific talk that sort of stresses prevention in this field. I think it's really important. But I guess I wanted to jump over to treatment when we have a drowning victim, and try to understand, right? So we have dive teams out here on the West Coast, and they're all about doing, being appropriately trying to be heroes in these circumstances. And so they will often push the limits out, beyond. They'll be responding to the shore, and it might be a 20-minute transport to get there. And so by the time they really get into the water, they're outside of 30 minutes or even outside of 45. And yet, everyone quotes that one case or that. And I guess I'd be interested, given all your experience and sort of your background, do you have a general practice of sort of the submersion time limits and And are there any exceptions to those that you consider?
Yeah, absolutely. Thank you, Tom. And great question that I get frequently and is always difficult to answer because it comes with so much emotion. And the reality is, if we had unlimited rescuer safety, unlimited resources, and unlimited abilities, then we could have that unlimited hope. And nobody wants to be the one that says we're calling off the rescue now for something that was survivable. But the reality is, getting the lifeguards out there, getting the helicopter launched, getting the swiftwater rescue team, getting the dive team into place involves both financial cost, but also human cost to those rescuers. And then take that even a step further. We've come a long way in the last 10 to 15 years to say, you know what, keeping everybody alive as long as possible should not be our goal. Our goal should be to relieve suffering. And that sometimes means that we need to pronounce somebody dead sooner than doing the 90-minute resuscitation only for them to be admitted and care withdrawn a few days later. And the reality lies somewhere along that unique spectrum. And when we just look at it from an academic standpoint, when subject to systematic review, underwater less than 5 minutes, good outcomes. Underwater less than 10 minutes, mostly good outcomes. Underwater more than 25 minutes, universally bad outcomes. And that could be death, or that could be severe neurologic morbidity. That 10 to 25 minute area, there's a lot of variability in the literature, but water temperature doesn't matter. Age doesn't matter. Salinity of the water doesn't matter. All that matters is how long they're underwater. So if you look at just a systematic review, 25 minutes of known submersion time is your cutoff for it to really be survivable with a good outcome. And my definition of a good outcome might be different than that specific parent's. That parent might say, even if my child is completely 24-hour dependent on a vent, a trach, a feeding tube, that's my child and that's what I want. And we would sometimes maybe push that out a little bit further. And there was a group out of Portsmouth in the UK that said, what if we just took all the outliers? And this is actually the algorithm that the UK Fire Rescue Services use. And they say, what if we created an algorithm that captured every outlier to these studies? And what they came up with was, you start your time zero when the first rescuers arrive, and whether that's the lifeguards or EMS. And then at 30 minutes, if the water temp is less than 6 Celsius and it's a small child, you go to 60 minutes of known submersion time. And then at 60 minutes, if it's small child and cold water, then you go to 90 minutes. And then nothing beyond 90 minutes. So 30 minutes, it would be where you call it in any water warm or any adult. And then cold water or a child, go to 60. Cold water and a child, go to 90 minutes. And that is not based on, here's a systematic review of chances of survival. It's how do we balance the potential hope of an outlier with the chance of survival, understanding that to perform that resuscitation on somebody that's been underwater for 2 hours may cause harm to the rescuers and may cause harm to the family, and it's not benefiting anybody. And so it really is a dynamic risk assessment that you're doing. But the heart of all of it is to have something in writing ahead of time, because in the heat of the moment of making those decisions, that's when rescuers get hurt. That's when rescuers sustain both physical and emotional injury, because they don't know what to do. They don't have that protocol. They don't have that policy to fall back on that says, it's been 90 minutes, we've pushed it to 100 minutes, it's getting dark. We need to call this off. We have a protocol and a medical director that's going to back us up when we do. And I think that gives realistic expectations.
Justin, that was super helpful. Thank you. Again, I think that's what we try to practice, is less than 30 minutes in most circumstances. I think the caveats you described are I think worthy of discussion for sure at a regional level, and so we'll bring them back. So thank you.
Yeah, absolutely, my pleasure.
Yeah, so Justin, this has been extraordinary, and it's amazing how much time goes by. So I'm super grateful for your willingness to join us and your contributions. We're going to look to wrap things up. And hey, everyone, I'm going to ask that Justin help me in putting together, kind of cobbling together a post-event email message for you with additional resources and so forth. That should be very helpful to all of you.
If I could jump in real quick and just take
Please.
60 seconds to talk about the last topic that I wanted to talk about, which is the non-fatal drowning. This is something that's often misconstrued in the media as delayed or secondary or dry drowning, and there's no such medical entity. But it's how do we describe and treat somebody who comes out of the water and has drowned, but isn't unconscious or in need of CPR. And I use the analogy of, we've all been at the dinner table and had some water go down the wrong pipe. You cough, you sputter for a few moments, it's irritation at the upper airway, and within a few minutes, you are 100% back to normal. If that's all that happens when the person comes out of the water, they're gonna be fine. But if it's any more cough or any altered mental status or any abnormal behavior that you would expect more than water going down the wrong pipe at the dinner table, they've drowned. 95 to 99% chance they're going to survive, but get them to the hospital. We'll put them on oxygen for a few hours, maybe keep them overnight in the hospital, but that is by far more common than fatal drowning. And depending on the study, 4 to 6 times more common than fatal drowning. So they always have symptoms the moment they come out of the water. There's no 100% asymptomatic period that later decompensates. And we'll include a link to one of the lay resources that we've developed called notoutofthewater.com that has more info on that aspect of non-fatal drowning.
Yeah. Just again, beyond all expectations, Justin, just a fabulous webinar and great Q&A period. And so we'll work together to share some additional resources with all of you. And again, thank you. This has just exceeded all expectations. Reminder to our participants, please provide us with feedback in the chat function. Was this helpful? Did you like it? Ideas for future webinars. Your feedback is critically important. So please do share that with us. Next month, talking about how, all of us in the resuscitation community really standing on the shoulders of giants who came long before us. I've got my good friend, Dr. Stafford Cohen, coming on to talk about a giant in resuscitation. That would be Paul Zoll. And I've had the pleasure of knowing Dr. Cohen for well over a decade. And I will tell you that in addition to being a brilliant cardiologist, he is a skilled storyteller and prolific writer, and he will tell us about Paul Zoll, the man. So keep an eye out for additional information on that. And I want to thank everyone on the call for their sustained efforts at helping people to live longer, healthier lives. And Justin, again, thank you so much. Mallory, thank you. Thanks to all of you. And we look forward to seeing you next month. Until then, take care, be well. Ciao.